So, good morning, everybody. For those of you that have not been to one of our webinars this season, my name is Mark Driscoll. I am the program manager with the Ohio AAP for the Preventative Health Program. I just have a couple notes on my end, and then I'll get our presentation started. I will be sending an email later this afternoon about how to apply for your CME and MOC Part 2 for this webinar, so look for that later this afternoon. And then I just want to also extend an invite that we end this season with a series on self-management and adherence strategies from the Cincinnati Children's Center for Adherence and Self-Management team. So I will also include a link to registering for that in my email as well. We hope to see you for those. And then without further ado, I want to thank Dr. Karras for speaking with us today on addressing vaccine hesitancy, and I will kick it over to him.
Well, good afternoon, everyone. Thanks for lunching with us today. I'm excited to talk about addressing vaccine hesitancy. I think this is my fourth favorite thing to talk about. I love talking about vaccines in general. Number one, safety, efficacy, how they work, why they're important. My second favorite thing to talk about is probably quality improvement. I think my third favorite thing to talk about is fishing. So if anyone needs a good lecture on walleye, bass, or pike fishing, please let me know. But my fourth favorite thing to talk about is addressing vaccine hesitancy. I'm Dave Karras. I'm a general pediatrician at Akron Children's. I'm also a board certified clinical informaticist. I do get to be professor of peds at Neomed, and I get to serve on the board of directors of the Ohio AAP. But enough about me. Let's talk about vaccines. So by the end of today, you should be able to identify some of the common drivers of vaccine hesitancy and misinformation. We should be able to apply some evidence-based communication strategies to address the concerns that families may have and figure out how to reduce their vaccine resistance. And you should be able to develop some effective responses to some common vaccine myths. So here is where it all starts. This is our recommended child and adolescent immunization schedule published by the American Academy of Pediatrics. And this is the evidence-based schedule that we have been using for many, many years. There were very few changes this year. In the spring, the CDC did release an updated immunization schedule. It was decided on a little differently than our traditional schedules. They looked at 20 peer nations, and if all of those countries universally recommended a vaccine, then they recommended it as well, and other vaccines were moved to either risk-based or shared decision-making. That schedule is in flux due to lots of legal and policy changes. So currently we are using the schedule published by the American Academy of Pediatrics. This has been endorsed by at least 12 large medical and healthcare organizations. And this is the only study that has been tested and studied for use in the United States. And this is the one that we are following. So this is what we are trying to prevent. This is a poor child with measles. And I know that this is the last thing that any of us want to see come into our clinic. It is going to mean that you would be in for a bad day. So our job is to prevent this. And the challenge is that the symptoms very much mimic a lot of the things that we see. So these are the symptoms of measles. You can see that by day 8 after exposure, kids can already have fever, cough, runny nose, and pink eye. I don't know about all y'all, but that is half of what we've been seeing in the clinic this spring. Fever, cough, runny nose, pink eye. Some of these kids have flu, adenovirus, the common cold. Often the measles rash may not start until day 14. So I'm very nervous about these kids who may show up before the rash starts. Now, typically the measles rash is going to start around the scalp, move down the trunk, and it's this maculopapular rash. After a few days becomes confluent. the one thing that will help us that typically these kids are very sick. They're usually not going to be happy and playful. They're often quite miserable, but certainly kids with risk factors or exposures definitely be concerned. Now, this is a graph looking at the rate of measles cases in the United States over time. And we can see that in the 1950s, there was a lot of measles going around, anywhere between 200 and 400 cases per 100,000 people. So lots and lots of people really were getting measles every year. And this really is one of the best graphs demonstrating vaccine efficacy. We have similar graphs for many different diseases, but measles is really one of the most profound. After the measles vaccine became widely available, cases of measles decreased precipitously. Um, by the 1980s, there were very few cases. There was a little bump in the early 90s, and that's when the second dose of MMR vaccine was recommended. And by 2000, measles was declared eliminated in the United States. That's the year I graduated from medical school. So I had assumed measles was a thing of the past and not something that I would have to deal with in my career. Unfortunately, that is no longer the case. These data are from the CDC looking at cases of measles, number of cases by week, looking at the past few years. And in the early 2020s, there was a few dozen cases a year, mostly imported from overseas or in small unvaccinated pockets. Unfortunately, this year things have definitely changed. In 2025, there were over 2,200 cases of measles, 11% were hospitalized, and unfortunately resulted in 3 deaths. 3 people died of an illness that is easily preventable. And in 2026, we are already over 1,700 cases for the year and on pace to far exceed last year's cases. I'm not aware of any deaths this year yet. And when we look at the national immunization for MMR, we can see why we're having these challenges. So measles, unfortunately, really is one of the most contagious illnesses known. Remember back to the COVID days when we were talking about the R naught, the number of people that would be infected from a person with a case of COVID. For COVID, most people at the beginning were likely to spread COVID to 2 or 3 other people. Measles is way more contagious. One child with measles is likely to spread it to 12 to 18 people if those people are all unvaccinated. So, in unvaccinated pockets, we can have very significant spread very quickly. And because it is so contagious, we need to have more than 95% of the population vaccinated in order to prevent that significant spread. But when we look at this map of our country, these blue states are the ones that have greater than 95% coverage. There's only about a dozen states that are high enough to prevent significant spread. And unfortunately, Ohio is not one of them. In fact, since COVID, we have been below 90%. And this is where we have a lot of work to do. And I hate to say it, but we are the ones that are on the front line. We are the ones that are having these conversations with families. And the good news is that families do trust us. We are the ones who really can make a difference. So let's look at Ohio specifically. This is looking at the percentage of kids entering kindergarten this year who had 2 doses of MMR vaccine. Ohio overall was at about 88.2%, and there really is a high degree of variability. It's not surprising that in Holmes County, with large Amish populations, we may have lower rates. But there are other places that are doing really, really well. Look at the Ohio River here. Several counties well over the 95% mark. But this is our community. This is where we are working, and this is what we need to do. So let's talk about vaccines. So, first of all, vaccines are not new. They have been around for a long, long time. This is a patient with smallpox. It looks horrible. Obviously, this child is very, very miserable. But smallpox was not the great pox, which was syphilis. I can't even bring myself to look up pictures of that. But this looks very, very miserable. These kids would get fever, vomiting, mouth ulcers, rash. About 30% of people with smallpox die. It has been found in Egyptian mummies, so it has been with humanity for a long, long time, and likely killed over 300 million people in the 20th century alone. Now, centuries ago, people had already learned lots of things about smallpox. They had identified that airborne transition resulted in much more severe disease, but that skin infections tended to be much milder. And inoculation may have been performed in China as early as the 10th century. And it's very easy. All you got to do is get some scabs from someone with smallpox, you grind it into a powder, and then you can place it in someone's nose or into a small cut. You give them a skin smallpox infection, which is going to be much milder than the airborne. Only about 10% of those people would die, but if you happen to survive, you had lifelong protection against smallpox. Let's fast forward to the late 1700s. In the United Kingdom, many people had identified that milkmaids tended not to get smallpox, but they did get cowpox because they were milking cows. And cowpox seemed to induce immunity to smallpox. Numerous physicians were testing cowpox vaccines. Again, very similar. You scrape some pus from someone with cowpox, you inject it into the patient's arms. Later, you expose them to smallpox. And if they don't get that disease, then you've shown that your new vaccine is successful. And Edward Jenner was the first to publish in 1798. How quickly after his first publication did we start to see the rise of anti-vaccine hesitancy? Well, this is an illustration published by the Anti-Vaccine Society, and it shows cows growing out of various people's body parts. And this was published in 1802. Within 4 years of Jenner publishing, there was already strong anti vaccine hesitancy. So, vaccine hesitancy is also not new. Fast forward to more modern vaccine hesitancy, and we have to talk about the former Dr. Wakefield, who published in Lancet and was convinced that MMR vaccines specifically could increase the risk of autism. I actually have read his paper, and it really, really is as bad as they say. There were 12 patients, there were no controls, and there really were serious scientific misrepresentations of the results. He performed endoscopies on all these children, trying to show that they had colitis. When the lab actually looked at the slides, most of those children did not have evidence of disease, so there were significant scientific misrepresentations. And Wakefield was actually funded by lawyers who were suing vaccine manufacturers. He went on to lose his license. The paper was retracted, but unfortunately, he continues to be a strong voice in the anti-vaccine area. But obviously, the real modern vaccine hesitancy has really come with the internet and social media, and we'll talk about that in a little bit. So this is the continuum of vaccine acceptance. Over on the right, we have the families that accept everything you want to give them. everything you say. They hang on your every word, and they are willing to accept any vaccine that you recommend. On the left, you have the people who really are going to refuse everything, and it is less likely that you are going to do a whole lot to change their mind. But there really is a large group in the middle that is just hesitant. They're not sure. They want to delay. They're uncertain. They have questions. And this is really where we can make a huge difference. The good news is that the continuum of vaccine acceptance does not actually look like this at all. This is what it really looks like. Again, these are data from the CDC looking at vaccine coverage by age 24 months among kids in this birth cohort. And look at these immunization rates. By 24 months, 92% of kids have had IPV, their polio. Almost 92% of kids have had hepatitis B, and almost 91% of kids have had a dose of MMR vaccine. In fact, only 1.2% of families refused all vaccines. Only 1% of kids have had no vaccines at all. So, really, the group where we can make a difference really is much smaller. There's only about 10% of families that are refusing or are concerned or hesitant. And this is where we really have the opportunity to make a huge difference. Let's look at some local data. This is a survey recently done by Bowling Green State University, and they surveyed people in Ohio, and this is what they found. 86% of Ohioans believe that vaccines are safe or very safe. That's a lot. 89% of people are confident that their physician provides them with the information they need to make informed decisions about vaccines. Our families trust us. They come to us to know what is best for their health. We are often their best and most accurate source of information when it comes to vaccines. And surprisingly, as high as 75% of people believe that vaccination should be required for school entry. So most of people really on our side. There really is strong confidence in the safety and efficacy of vaccines. So the good news is that most of our families do agree. But obviously, there are families that are concerned, there are families that are hesitant, and we really need to understand why they feel that way if we want to be effective at moving them towards acceptance. This is a key driver diagram. This is one of the tools that we use in the quality improvement space, and it helps us create our mental model about what is going on and what is causing people to be hesitant. So if our aim on the left here is to increase the percentage of children who are up to date on their recommended vaccines, we can look at what some of the primary drivers are going to be. This is adapted from the World Health Organization, the psychological antecedents of vaccination, and they tried very hard to make them all start with the letter C, but sometimes the words aren't the best. We're going to talk about some of these in more detail, but let's look at these. So first, obviously, is confidence. People have to trust in vaccines and in the health system. And unfortunately, there have been a lot of the things over the past decade that have led to lots of mistrust. Second is complacency, and this is not about not caring, but at a low perceived disease risk. If families don't believe that these diseases are out there, they are not going to be too concerned about getting their children vaccinated. So many families believe that these diseases are rare or that they're mild or that there are low consequences associated with not vaccinating. For some people, they really have constraints. There may be practical and logistical barriers. Some families struggle with access, insurance, language, literacy. For some people, it's calculation, I should say miscalculation, this excessive risk analysis, where they feel that the risks of vaccinating are much higher than the risks of not vaccinating. I think collective responsibility has one that has really decreased over the previous decades, and it's the idea that we vaccinate our kids to help protect our community, that we're really all in this together. And unfortunately, it feels like there have been weakened social norms, more individualistic framing. It's really outside the scope of this talk, but really learning how to improve that collective responsibility is going to be so important. Looking at faith-based partnerships, getting to people where they are in with their communities and talking to their communities, and really talking about that social norm messaging, that vaccination is something that we do to prevent our entire community and not just our individual children. And then certainly making sure that your own clinic has a very strong pro-vaccine culture. So again, some of the drivers of hesitancy for some people, they are going to have real practical barriers. Are we working to improve access in our clinics? Are we able to provide evening hours, weekend hours? Are we able to vaccinate at non-well visits? Uh, and then are we making sure that our own clinic really does have a strong pro-vaccine culture? Is everyone in your clinic giving that same strong message, from your secretaries to your medical assistant to your providers? I hate to say it, but when I first started practice, we covered a hospital for high risk deliveries, and there was a nurse there who would actively talk families out of the Hep B vaccine. If there are healthcare workers that are sending contradictory message, that is going to make families much more hesitant and much more mistrustful against the messages that we're having. So make sure that everyone on your staff is able to give that same strong pro-vaccine message. Obviously, one of the big ones is confidence, and there has been so much going on that has caused people to lose trust in healthcare and in vaccines. People are so strongly influenced by their culture and by their communities. And unfortunately, there have been a lot of things that very legitimately have caused people to lose trust. Look at our own CDC. This year, they have gone back on previous recommendations. And so, if your own government is giving you conflicting information, of course, you're not going to fully trust their healthcare system. We all know of stories where pharmaceutical companies have put profit ahead of patient health and safety. And when we see that, of course, we're going to be concerned that maybe the same thing can be happening with vaccines. People are so tied to their ideals and to their values and to their communities. It can be very difficult for the lone pediatrician or pediatric nurse practitioner to make a big impact on that. And obviously, we all know that social media and traditional media have made our jobs much more difficult. We know that the internet and social media have really acted as a megaphone for those anti vaccine messages. It makes it so easy to spread misinformation and disinformation, and it gets amplified. We know that the algorithms are set up to induce people to click on things, and the more emotional and outrageous it is, the more likely that people are to click on it. So, unfortunately, those scary stories tend to rise to the top and get spread. And I do have to criticize traditional media as well. Again, the more eyes are going to come to things if it really is emotional and sensational. And so, as soon as there's any story that shows that someone was harmed by a vaccine, the media get out there and say what happens, often without getting all of the facts first. And this can be so damaging. For instance, there was a young girl in Wisconsin who died a day after her HPV vaccine. It hit the news. Oh, girl dies after her vaccine. But when they finally did an autopsy, they found that the actual cause of death was a diphenhydramine intoxication. She did not die of HPV vaccine. She died of a Benadryl overdose. It's tragic. It's horrible. But the media then is not able to go back and retract those headlines. A similar thing happened in the United Kingdom. A girl died hours after her HPV cancer vaccine hit the news. The National Health Service actually stopped vaccinating against HPV for a while. But when they did autopsy, they found that the girl had a giant chest tumor. She did not die of HPV vaccine. She died of her cancer. Again, horribly tragic. But these stories get out there, these headlines are seen, and of course, families are going to be concerned about vaccinating their children. And again, for a lot of families, it really is this risk misperception. It's overestimating the vaccine's harms, seeing how social media and news stories can make it seem very risky, and very much underestimating the disease severity. Families are not seeing kids with measles, not seeing kids with polio. We've lost that collective memory of how bad these things really can be. So, for many families, they're concerned about their baby crying when they really need to be concerned about their baby dying. And again, this complacency, it's not due to indifference, it's just due to that perceived risk. And again, we know that events of the past decade have really led to increased polarization, decreased pluralism, heightened group identity. The search algorithms and social media are really polarizing and sensationalizing. And we've all seen that the more that people identify with their group, the more likely they are to accept their group's beliefs. So, what do we do? Well, the good news is you are the most common source of vaccine information, and you are the most trusted source of vaccine information. Families really do trust us, and often we are the only person in that family's life that is going to be talking to them about the importance of vaccines. And that's why that mantle weighs so heavily on our shoulders. And we got to figure out how to do this well. Again, most of us don't feel comfortable with this. We don't like having challenging or emotional conversations with families. And so we need to practice, we need to figure out how to have these discussions, even though we may not like to. We are the ones that it falls to. So for most families, it is really all about making that strong recommendation and using the presumptive format. And this is what you should do with the vast majority of patients. Today, Latrice needs her tetanus, diphtheria, and pertussis booster, her HPV cancer vaccine, and her meningitis vaccine. Making vaccination the default means that fewer families are going to opt out. Assume they are going to do it, and it is much more likely that they will. Because the fact is that immunization still is the social norm. 90% of Ohio's children are vaccinated. And using that presumptive format is going to be very effective for first time discussions and even for mildly hesitant families. Here are some presumptive pearls from the AAP's web pages on vaccine hesitancy. I think these are really, really helpful. First, tone and body language do really matter. Don't make it sound like a question when you're delivering in that presumptive format. Make good eye contact, square your shoulders, don't be distracted. Know what that child is due for before walking into the room. And you can use that presumptive format even when they have expressed hesitancy in the past. I know we've talked about vaccines last time, but I'd love to get her caught up today. She is due for 3 shots. And again, all of your staff can start with this same presumptive format. Everyone should be able to say, hey, your child's due for these shots today. I'll be getting them ready. And you can use it even after someone has let you know that that family may be a little more hesitant. One important thing when using that presumptive format is not to then quickly switch to a more questioning format. So don't say, so we're going to do 3 shots today, or is that what you want to do? Say, you're due for 3 shots today, and then wait for the family to respond. So what if they say no? Well, that's our opportunity to really respond with genuine curiosity and empathy. Again, families are not saying no because they want to hurt their children. They're saying no because they think that it is in the best interest of their children. So we actually have the same goal. We are all there to try to figure out what is the best for that child in front of us. And we know that an argument or an attack is only going to be making people more defensive and more hesitant. So we have to figure out what are the barriers and how can we address these families' concerns. Well, the only way to identify those barriers is to ask. And motivational interviewing is a great model with which to do that. This is not a motivational interviewing lecture, but we're going to go through some of the key points, and that is what's going to really let us build a true family-centered partnership. So again, motivational interviewing is moving people towards behavior change. It's not telling and persuading, but really about listening and guiding, helping them get to that decision on their own with a little help from you. So again, it's going to be a partnership and not a persuasion. It's trying to figure this out together. We want to elicit the family's feelings and then provide our opinion and our facts to help move them towards acceptance. So, what worries you the most? And hearing what it is that concerns people. And it is so important to support people's autonomy in this. People are going to be much more open to change when they don't feel significant pressure from you and don't feel like you are judging them for their decisions. So let's look at some motivational interviewing tools and how we can use them specifically with vaccine hesitancy. So the first goal in motivational interviewing is to ask open-ended questions. This is giving families the chance to respond and gives you a chance to hear what they're feeling about. In your mind, what is the risk of vaccinating today? Then you wait and hear what the family has to say. They're going to tell you what their concerns are. Now, before you start answering all of their questions or concerns, next you want to affirm them. You want to say, oh, I can see how much you care about your child's safety. You want to be able to reflect what they've just said back to them. This shows that you've been listening, that you're engaged, that you're empathizing with their feelings. Yeah, I see you want to keep your baby safe, but you're concerned about side effects. Then you want to ask permission to share. May I share with you what I know about the risks of the vaccines? And again, I must keep stressing this, supporting the family's autonomy, letting them know that they are the ones who are going to make decisions about vaccination, that you're not going to do anything without them. Only you can choose what is best for your child. In light of what we talked about, what would you like to do today? Here is a nice motivational interviewing conversation example straight from the American Academy of Pediatrics. And it's just a little sample of what that conversation can sound like. So the provider says, you sound pretty certain that you don't want Johnny to get the MMR vaccine. No, I don't, says the parent. Well, I just want to say right up front that this is your choice. My job is to share the best information that I have about the vaccines and help you with your decision. But you are the one who decides. Again, we're supporting their autonomy. The parent says, okay. Tell me what you know about MMR vaccine and autism. Again, open-ended question lets that family express their feelings. Well, my cousin said that her daughter was fine until she got the MMR shot, and I've read a lot about this on the internet too. How can it be a coincidence? So you obviously have doubts. Given your family experience and what you've read, I totally understand. Again, we're reflecting back to the family what they've said. We're affirming their feelings. And the provider can say, I've done some careful study about MMR and autism, and I have some information that may help. May I share that with you? I guess. And you get to share about MMR and autism. There's no data showing any increased risk. And you can talk about the positive benefits of getting vaccinated. And you can end with, so What do you make of all that I've shared? Parents say, I'm not sure. I guess it makes sense though. You can ask, how would you like to proceed today? And you say, I don't know. I guess we can go ahead with it this time. Now, you're not going to be successful every time. It doesn't always end this well, but the more often you do this, the more often you are going to be able to talk to families and make some headway. Again, these are some more examples from the American Academy of Pediatrics on their publications around vaccine hesitancy. I'm going to go through this one more time. Again, start with that open-ended question. It helps you really explore and understand the family's stance on vaccination. If you are affirming them, that's going to improve their engagement and help open that discussion. Reflecting back their statements to them is really going to encourage that partnership, deepen that rapport, and ask permission to share. That's going to put them in a less defensive posture and make them much more receptive to the information that you want to share. And again, always, always support their autonomy. That being said, this is a decision that only you can make. So again, here's a list of lots of different questions and statements that you can use. Some of them I like, some of them I don't care for, but really, they're all going to be different. Everyone has a different style. Every provider talks to families different, and any family is going to be coming from a different place. And so you're really going to have to learn how to tailor this to your own communication styles. So let's look at some common vaccine myths and how we can address them with families. Obviously, there are lots of different concerns that families may have. Some families still feel vaccines don't work or that the diseases are not that dangerous. Families obviously are concerned about autism, mercury, aluminum, formaldehyde, getting too many vaccines at once. So let's look at some of these common vaccine myths and look at some of the facts that we can give back to help contradict them. So first of all, do vaccines work? Yes, smallpox was eradicated by the 1980s. There is no one with smallpox, and hopefully it will stay that way. Polio is only endemic in Pakistan and Afghanistan. We are so close to getting rid of polio. And again, look at this measles. Once that vaccine was introduced, measles cases fell precipitously. Yes, time and time again, we have shown that vaccines are very, very effective. Are vaccines safe? Yes, all vaccines are vigorously tested for safety and efficacy. I've used this slide for many years. It was just last night that I saw that it said they were vigorously tested. You need to vigorously shake them, but they were in fact rigorously tested. Serious side effects are very rare, only 1 to 2 severe allergic reactions per million doses. We do have a passive vaccine adverse event reporting system that really, really does work. We are able to study vaccines both prior and after licensure, and we want to make sure that they are super safe. Again, we are injecting healthy babies with these things. We want to make sure the risks are as low as possible. And the good news is that the data showed that our vaccines are very safe. This is one of my favorite case studies. This is an immunization called RotaShield. This was a rotavirus vaccine that was approved back in August of 1998. I suspect some of you on this call are young enough that you may have actually received it. They had identified some cases of intussusception in early trials, but it was not statistically significant. So the normal rate of intussusception is about 1 in 3,000. This vaccine increased the risk by a tiny amount, 1 to 2 in 10,000. But after licensure, they were able to see this signal in the VAERS data, and they were able to see that RotaShield did increase the risk, and they were able to withdraw it from the market. How long did it take from licensure to withdrawal? 9 months. Within 9 months of this vaccine being licensed, we were able to see that there was risk through that VAERS data, and we were able to pull it from the market. So I can very confidently say that vaccines are very, very safe, and we very rigorously test them to ensure that they are. Will too many vaccines overload the immune system? Yes. If you administer 10,000 vaccines at once, it would likely deplete anyone's B cell capacity. So don't do that many. But 4 or 6 is certainly fine. It may be a little ouchy, but it will not overwhelm your immune system. The immune system, the immunization schedule that we have is the one recommended by the AAP. It has been thoroughly tested for safety and efficacy. There are no data on alternative schedules. There is no data showing that spacing out vaccines is any safer. Again, the vaccine schedule that we have is safe. And we know that administering those vaccines together is absolutely appropriate. Do vaccines cause autism? No. So many large scale studies have found no link between vaccines and autism. Thimerosal was a preservative that contained mercury. There was concern that over time kids could have elevated levels of mercury in their system that could cause neurocognitive declines. Thimerosal was removed from all single dose vaccines years ago due to that theoretical risk. There has been no decrease in the rates of autism, so we know it was not the thimerosal. Do vaccines contain aluminum? Yes, aluminum salts are used as adjuvants to enhance the immune system response in many vaccines. They have been safely used for 70 years. This allows us to use lower doses with lower side effects and better efficacy. Aluminum is the most common metal on the planet. In children who receive vaccines, they can get up to 4.4 milligrams of aluminum by 6 months of age. The fact is, most people consume double that amount every day. There's aluminum everywhere. And again, this has been rigorously tested. A study of 1.2 million children showed that there was no increase of asthma, allergies, autoimmune disorders, or neurodevelopmental delays based on the doses of aluminum that they may have received. So aluminum is very, very safe. Are vaccines made from aborted fetuses? Kind of. Varicella, rubella, and Hep A vaccines are all grown in human cell cultures that were obtained from fetuses decades ago. There is no human tissue in any of the vaccines. And even the Vatican has said that it is absolutely appropriate for Catholics to get vaccinated with these vaccines that were grown in human tissue cultures. Is my child at risk of getting that disease? Well, it really depends. Polio? Probably not. Strep pneumo? Sure. Chickenpox? Probably, and it's going to be yucky. Cervical cancer? Yes. 1 in 45 unvaccinated and unscreened women will go on to have cervical cancer. That is a lot. And even with regular screening, that number can be 1 in 500. The risk to a severe reaction to the vaccine is less than 1 in 1,000. Vaccines are safe and effective. The diseases are not. So what do we do? Well, we know paternalism is not going to work. We're not living in the 50s anymore. Arguing is not going to work. It's just going to make families more defensive. It's about building that empathetic relationship. It's not a doctor and a patient, but it's two people trying to figure out what's best for the child that they both care about. So what do we do? I hate to say it, but we have to practice, because none of us is great at having these conversations. And the only way we're going to get better at anything is through practice. Now, I have good news. There are ways to practice outside of the exam room. Motivational interviewing is a great tool to use, but we have to get comfortable with it. We have to learn how to use it. We have to anticipate the questions that families are going to ask, and we have to have some ready responses. And I've got some great ways for all of you to practice these things. The first is body swaps. This is an organization that provides online modules that let you practice motivational interviewing skills in a virtual reality type format. You can do this on your laptop, or if you've got VR goggles, you can log in with those and feel like you're actually in the room having a conversation with the family. The module's fun, it's interesting, it's educational. I learned a lot. I strongly recommend everyone trying out the Body Swaps module. You're going to learn a lot about motivational interviewing and how to use it with patients and families. But here's the next one that I don't know if other people have thought about yet, but as I was preparing this talk, I wanted to figure out what are good responses to some of the common things that families are going to ask. And how do I answer those questions better and more effectively? How do I practice my motivational interviewing skills using the questions and responses that I'm pretty certain families are going to have? Well, guess what? We all have access to artificial intelligence now. And these chatbots are remarkably good. Let me show you some of the conversations I had with my large language model AI. So this is the prompt I gave it. Can you and I practice motivational interviewing together? You be the pediatrician, I'll be the father of an unimmunized 4-month-old who's there for their preventive care visit. And this is what the AI said. Absolutely, it's a great way to sharpen the skill. The AI is going to be the pediatrician, and I'm going to be the parent. He's going to use that collaborative tone and reflective listening. Let's see how the AI did. Hi, it's good to see you and your baby today. He looks like he's growing real well. At this age, we talk about the next set of vaccines to protect him from things like whooping cough and meningitis. Before we go into details, can you tell me what you've been thinking about vaccines so far? We are not doing any shots today. Thanks for being clear about that. I appreciate you telling me up front. It sounds like you've made a pretty firm decision. Can you tell me a little about what's led you to feel that way? My family does not believe in them. Got it. That sounds like something that's really important to you and your family, and probably something you've thought about for a long time. When you think about vaccines for your baby, what concerns you the most? He's too young to be injecting him with things that we don't understand. So you can see how that AI was able to script all of that motivational interviewing, and you can see how it would respond to some of the common questions and comments that your families would give. Next, you can switch roles. I'm going to practice the motivational interviewing, and the AI is going to be the vaccine hesitant family. And you can even ask it to give you real time feedback as well. So now I'm on this side, or now the AI is the vaccine hesitant parent. Yeah, we're not actually planning to do vaccines today. I've just heard too many things, and honestly, I don't think they're necessary. Thanks for letting me know. Can I ask about what you've been hearing? Just a lot of stuff online, like that they can overwhelm the immune system and that there are toxins in them. It just doesn't seem worth the risk to me. Then the AI can give you feedback on how you're doing. So it said I did really well. It said I set a good tone, it helped lower defensiveness, but then it even can give you some responses on some things that you can do better. So I strongly recommend all of you to go and try this with your favorite AI and practice with some of the more complicated questions that you know that you're going to get for families. That way you're ready to respond when they come up in the office and you will be much better prepared. I do want to share some resources that the Ohio AAP does have to offer. We have our Moby and Ties programs where people can come out to your office and look at how your office is doing with vaccines, get your immunization rates, talk about quality improvement projects that you can work on. We have the Ohio Champions for Vaccines, where we help people with social media outreach. On the Ohio AAP's website, we have lots of resources for providers on all sorts of health topics, including vaccine hesitancy. We do have our fast vax facts. Don't try to say that, but it allows families to ask all sorts of questions about vaccines that they may have. So these are great resources to share with families as well. So in summary, vaccine hesitancy really is as old as vaccines. I encourage all of you, be curious, not judgmental. Again, any family who is hesitant about vaccines is only doing so because they are concerned about their child and they want to do what is the best thing for them. And the only way we're going to overcome that is building a real personal, respectful, and empathetic bond with that family. That relationship built in that exam room really can be so powerful. And motivational interviewing certainly can be a great tool to get there. Uh, I've included lots of different references on vaccines and vaccine hesitancy. And again, I encourage you all to try the body swaps or even your AI to help practice some of those skills. And thanks for your attention. I'm Dave Karras, and happy to respond to any questions.
Oh, thank you, Dr. Karras. So we did have a few in the chat, but also we have a few minutes for questions. If you have any, feel free to either unmute or enter your questions in the chat, and hopefully we'll get to them. The first we had is, do you recommend after saying the presumptive statement to follow up with your nurse will be in after I step out and give the vaccines?
If families have consented, then yes, you can say the nurse would be in. I'm trying to see how I can see the chat. You'll have to read them. Sorry.
Okay, that's okay. And then Dr. Peltier entered a resource in that people can take a look at. Someone asked about the slides. I will be sending out our preventative health website, which will post the slides to. And then we have a comment that we love the concept of the role play with AI. And do you know if Fastbacks Facts has an app? That's a good tongue twister.
I don't know the answer to that question.
And then it looks like Elise Berlin has her hand up. You're welcome to unmute and ask a question.
Hey, thank you so much, Dr. Karras. This was a fantastic presentation. I was the one who asked about the kind of after the presumptive statement. I wasn't sure if you kind of the recommended approach is to kind of say it and then a little pause and kind of like, assess.
Yeah, you certainly want to wait and get the family's assent or consent. If the family is not interested in vaccination, obviously they're going to make that clear. But if I say, oh, you're due for 3 vaccines today, your tetanus or whatever, I usually talk about risks and side effects. If the family's not expressed any hesitancy about that, and then I say, yeah, nurse will be in shortly with those vaccines. It's only when families express hesitancy or outright say no that we start to need to use some of these tools. How do you do it?
She's unmuting. I think. I can unmute you too, I think.
Yeah, I usually take a pause, and I'm an adolescent medicine doc in pretty subspecialty practice, so I'm usually talking about HPV vaccination. And so I think I can be potentially a little bit more presumptive about how I'm doing it, and not because usually I say a little spiel about how good the vaccine is and why it's important, and then say, hey, can we vaccinate today? As opposed to just saying, hey, looks like you're not up to date with your HPV vaccine. I think in my practice, I would say something like, I'd love for us to go ahead and give that today. Does that sound good? Is that
That's
still okay? Thank you. And then will you please unmute me or mute me?
Yes. Here you are. Just a few comments on the loving the idea of the AI, and that there will be a bipartisan bill introduced into Congress called the Strengthening the VFC Program. And then if there aren't any other questions, I'll go ahead and close us out. So once again, I will send an email shortly about how to apply for your CME and MOC Part 2 credit. That will include the link to where you'll find the slides. They may not be posted today, but they will soon. And then also how to register for our upcoming series on self-management and adherence. And then a few people mentioned MI, and it was mentioned in the presentation, so I will shamelessly plug also that we held a 4-part series on motivational interviewing earlier this year, back in January and February, that is also on the Preventative Health website. You can see the slides, some of the resources, and recordings of those webinars as well for tips on how to use MI in your visits. And then if there are no other questions, I'll just say again, a huge thank you to Dr. Karras for presenting today and to the Ohio Department of Health for being our sponsor for today's webinar. And I look forward to seeing everyone in the future. Thank you.
Thanks all.